Spine is a complex and brilliant mechanical structure, a column of articulating vertebrae separated by intervertebral discs. This structure provides central support, allows upright posture, and enables a wide range of motion. More importantly, it forms a protective bony canal for the delicate spinal cord. From this cord, spinal nerves exit at various levels to supply motor control and sensory feedback to the trunk and limbs. Our job as clinicians is to understand this system with precision, move beyond guessing, and apply a methodical, evidence-based approach to resolve pain and restore function. This is a foundational crash course with clear, actionable guidance for assessment and treatment of common spinal conditions. We will dissect the spine region by region, from cervical to thoracic to lumbar. The spine is a segmented chain with specialized roles: the cervical for mobility, thoracic for stability, lumbar for strength and load transfer. Understanding these demands drives differential diagnosis and targeted intervention. Specificity beats one-size-fits-all. The cervical spine consists of 7 vertebrae, labeled C1 to C7, the smallest and most mobile in the column. The atlas, C1, and the axis, C2, form a unique articulation permitting head rotation and nodding. C3 through C7 resemble other vertebrae yet preserve wide motion in flexion, extension, side bending, and rotation. Critical nerve roots exit between these vertebrae, forming the brachial plexus to power and sense the entire upper limb. A delicate balance of mobility and stability enables head control and arm function. Common presentations include cervical muscle strain and ligament sprain, often from poor posture or sudden unguarded movement. Cervical radiculopathy stems from nerve root irritation, frequently a herniated disc or osteoarthritic bone spur. It causes neck pain, numbness, and weakness radiating down the arm. Cervical spondylosis leads to stiffness and pain. Whiplash-associated disorders and cervicogenic headaches are also common. Typical signs: localized neck pain, stiffness, and a noticeable loss of motion. With a nerve root, expect dermatomal pain, pins and needles, or numbness into the shoulder, arm, or hand. Symptoms often worsen looking up during extension or turning the head. Assessment begins with careful questioning, posture inspection, note forward head and asymmetries, palpate paraspinals, facets, spinous processes, test active and passive ROM in all planes, and note pain or limits. The thoracic spine, T1 to T12, is defined by its connection to the rib cage via costovertebral joints. This semi-rigid structure protects the heart and lungs. Inherent stability means less mobility than cervical and lumbar regions, especially limited flexion and extension. Primary movements are rotation with some lateral bending, vital for throwing and reaching across the body. Less prone to herniations and instability, but not problem-free. Common issues: muscle strains from poor posture, rotational overuse, or heavy lifting, thoracic and costovertebral joint dysfunction. Thoracic outlet syndrome compresses nerves or vessels between clavicle and first rib, causing arm symptoms. In older adults with osteoporosis, minor events can cause vertebral compression fractures. Patients report mid-back pain, dull ache, or sharp interscapular pain, aggravated by sitting, deep breathing, coughing, or twisting. Radicular pain is less common, but can wrap around the chest wall. Always screen for visceral referral and non-musculoskeletal causes. The lumbar spine consists of 5 large, robust vertebrae, L1 to L5, the biggest and strongest in the spine. Their size reflects function, supporting the upper body and transferring powerful loads during lifting, walking, and running. Large back and abdominal muscles attach here, forming a dynamic, stabilizing core. The spinal cord ends around L1-L2. The cauda equina continues down, exiting to supply legs and pelvis. This is the most common site of spine complaints. Most are non-specific low back pain. Lumbar radiculopathy, sciatica, occurs when a nerve root is compressed, often by a disc herniation. Expect pain, numbness, and weakness along the affected distribution. Spinal stenosis, narrowing of the canal, common in older adults. Spondylolisthesis, one vertebra slips forward on the one below. Symptoms range from localized pain to diffuse regional ache, sharp or dull, often worse with bending forward, lifting, prolonged sitting, or standing. Radiculopathy hallmark, pain radiates down the back of the leg, past the knee, into the foot, in a nerve root pattern. Neurogenic claudication, leg pain, cramping, and weakness brought on by walking, relieved by sitting or bending forward. Begin with gait, posture, and sit-to-stand transitions. Test lumbar range, especially flexion and extension. Look for movements that centralize or reduce symptoms. Use SLR for neural tension, test strength, sensation, and patellar and Achilles reflexes to rule significant nerve compression and guide care. While most spine pain is mechanical and responds to therapy, remain vigilant for serious pathology. Red flags mean stop manual care, pause exercise, and make urgent referral. Significant trauma, falls from height, high-speed MVAs, warrants immediate medical evaluation. Unexplained weight loss, fever, chills, or unrelenting night pain may indicate infection or malignancy. History of prostate, breast, or lung cancer raises suspicion for bone metastasis. Cervical, dizziness, diplopia, dysarthria, dysphagia, or drop attacks. Consider vertebral artery insufficiency. Thoracic, sudden severe pain after minor trauma in older adults. Suspect compression fracture. Lumbar, cauda equina syndrome, saddle anesthesia, new bladder or bowel dysfunction, or progressive leg weakness, requires immediate ER evaluation. Failure to act risks permanent paralysis and loss of sphincter function. Effective treatment goes beyond the pain site. Use an integrated approach. The spine is the central link in the kinetic chain. Dysfunction in one region forces compensation elsewhere. Poor thoracic mobility can overwork the neck and low back. Hip weakness or stiffness shifts pelvic mechanics, increasing lumbar stress in walking and squatting. Always assess above and below the complaint. Education is the cornerstone. Clear, non-threatening explanations reduce fear and anxiety. Teach load management and spine hygiene, safe lifting, proper sitting posture, and activity pacing. Empower patients to self-manage and prevent recurrences. Exercise must be specific and progressive, matched to goals and stage of recovery. Cervical, strengthen deep neck flexors to improve head posture and control. Thoracic, restore mobility. Focus on extension and rotation, consider targeted exercises and foam rolling. Lumbar, build core endurance and stability, challenge abdominals, back and hips without provoking pain. When a directional preference is clear, repeated movements in the pain-reducing direction can be powerful. Manual therapy is a facilitator, not a cure, creating a window of reduced pain and increased movement to engage exercise and restore function.